64-year-old female lady weighing 65 kilos. She's not frail. She's totally independent. And her symptoms nowadays, she complains of easy fatigue. In fact, she was born with a congenital Ebstein anomaly, and there was also a small ASD. 11 years ago, in 2012, she underwent surgical plasty, which wasn't successful. 1 week later, this was performed at another hospital. He had tricuspid valve replacement with a 31 millimeters bioprosthesis. We didn't know which was. In fact, it seems that it's a lap core, and she also had her ASD closure. She's very low risk for operation. So now this lady has a mixed lesion in the tricuspid bioprosthesis. She's on aspirin, statins, and naloxone. On physical examination, she had jugular distension. Her liver was 2 to 3 centimeters below the costal margin. And she also has the typical regurgitation murmur in the tricuspid position. With regards to TTE, transthoracic, she has a huge right atrium. This is the area. Her septum is intact, no ASD, a little bit of RV dysfunction, a calcified bioprosthetic valve with severe TR and a mean diastolic gradient of 7. Her estimated RV systolic pressure was 28. This is the TE. You can see the Doppler pattern near the atrium in the inferior vena cava with no variation during respiration. So you can see how big the right atrium is, right?
Actually being larger than the heart.
Larger than the heart. Yes, it's because of its compliance, right? Atrium become really, really big. The septum is not moving well. We're going to see some more pictures with TE here. You can see how immobile one leaflet is near the septum, and you can have an appreciation of the anatomy using 3D TT.
Okay. And it seems to be a LabiCore, and we got the diameters here, the true internal diameters, 27 per 28. So maybe she has a 31 LabiCore.
Wow. Okay.
So we simulate the implantation of a balloon expandable valve in the tricuspid position. We simulate 2 sizes, 29 and 30.5 millimeters. As part of our evaluation, we also look for some tortuosity, particularly in tricuspid patients, the inferior vena cava related to the tricuspid annulus. And this is the suggested implant view that we're gonna use for tricuspid valve aerial 7, caudal 1.
The Ebstein anomaly can present in 2 different settings. The most severe presentation is fetal and neonatal presentation with pulmonary atresia, functional or anatomical. And this is a very difficult disease to deal with, and there is a very high mortality in this setting. And then there is the presentation that occurs during life after neonatal period. And usually some of the patients are completely asymptomatic during infancy. And the main thing, there are 2 types of presentation. One is cyanosis. If they have an ASD, they have right to left shunt at the atrial septum, and they can get polysystemic, and they are at high risk for embolic events. And the other presentation is with intact septum, and they have heart failure, and the right atrium is very dilated with severe TR, and all the right heart failure presentation. So in the past, we used to have lots of surgeries in these patients. The surgical repair was very frustrating in the past. And since Dr. Da Silva, with his cone procedure, started with this technique, and he has treated people from everywhere in the world, the prognosis for this disease improved a lot. So these pictures were taken now today, and you see how big is the right atrium, and you see how calcified is the prosthesis. There is no good movement of the leaflets, they are calcified. And you see that the function of the right ventricle is not good, especially the septum. It bulges to the left side. And we can see here how stenotic is the prosthesis. And we see a big regurgitation. Of course, the atrium is so big that it seems smaller.
You have stenosis and regurgitation.
Yes,
it's double dysfunction.
Double dysfunction,
Okay.
exactly. And here we have the gradient. She's anesthetized and she has 6 millimeters mean gradient. And the next one shows the RV pressure is low, usually low, because it doesn't generate good pressure forward. And we see that there is only one leaflet moving well, which is the anterior. The other ones are stopped. And that's the reason of the prosthesis dysfunction. This is the right atrium. See how big it is? We can see there is still leaflets left. And you see here, the valve is still there.
Yes.
So, of course, this plasty was not successful, and she ended up with a prosthesis. And then this is the natural history of this situation now with a dysfunction.
Okay,
To
so we left the catheter.
Okay.
The catheter is there.
Yes.
Pigtail, and we're gonna put the wire. It's a Lunderquist wire.
Yeah, sometimes we need to use a deflectable catheter to cross the tricuspid valve. But in this case, in fact, it was very
So the
easy.
case you have done, you have used the wire in the pulmonary artery?
No,
No.
Both. We've done both.
Okay.
Yeah.
So do you have any special consideration because of the trabeculus that you see in the right ventricle that's different
I
from the
think that
left?
in this case,
Mhm.
because of Ebstein anomaly and the characteristics of the right ventricle, so trabeculated and a small ventricle, because we are going to use a balloon expandable valve.
Abre rápido.
I think that for dedicated tricuspid valves that are under investigation, they are self-expandable. So this might not be a problem. But when we use a balloon expandable valve, particularly when we oversize, so maybe there's a risk of damage the lead.
I see.
So I lost the wire position, the catheter position, as expected, because the Lunderquist wire is so rigid. So it made my catheter come back.
So you're going to place again?
Yeah. We're going to. Sometimes this is the hardest part of the procedure.
So we are doing live. It's normal.
Yeah, no problems.
No, be calm.
You can also use the jugular for this kind of procedures.
So can we also use jugular?
Yeah, we have done some cases.
With jugular.
Yeah, but
It's more anatomical, it's easier.
in terms of logistics and ergonomics, it's more. I think it's more difficult. You are at the head of the patient, near to the X-ray tube. So
I see. Now we bring in this is a JR catheter.
JR,
Yes.
and very, very distal. Okay. We use
So in the past, we did that when we were doing a diagnosis for mitral stenosis.
yeah.
So I have not done this so
wedge.
far for a long time. Bring a catheter in the wedges.
So we are planning to use a valve which is called my valve.
Now we are doing this in patients with diastolic dysfunction, with heart failure with preserved EF. We are doing this in our cath lab, in diagnose, doing exercise, and measure the wedge pressure. And now Carlos is bringing the stiff wire. Is that correct, Carlos?
Yeah.
Okay. Do you have any difficulty just to advance it?
Yeah. We're having some problems here. That's good. In order to advance the system,
Okay,
this we're going to use 30.5 valve. Remember that the inner diameter was 28.
all the implantation have you done is without a pre-dilatation, or you did any pre-dilatation?
No, generally you don't need. If you have a good wire position and
So if you have a only stenosis with a calcified valve, do you think it would be a good idea to dilate or not?
I don't think so.
No.
No. It's my valve, the
Mhm.
name of the valve. It's bovine pericardium
Mhm.
leaflets, and the metal mesh is nickel chromium.
Okay, perfect.
Okay,
So are you
so
bringing
this is the sheet. Yeah,
the introducers set? Okay, it's a
Não, Gacica.
14.
This is a 14
No,
device.
Okay.
Sica.
This is a 14 sheet.
This is a 14, and we're gonna use the dilator
Mhm.
to make it.
So Marcelo is
Yeah.
holding the wire,
Yeah,
and Carlos is bringing the
yeah,
introducer. It's quite easily. So you were in the vein.
yeah. And first we put a ProGlide. We pre-closed the
Yes.
puncture here.
So we try
Okay.
to use only one ProGlide tube.
Only one.
Only
Yeah.
one.
So this is the dilator.
Mhm.
You can use the 14 sheath with the smaller valves,
Okay, perfect.
right? But because we are doing the case with a 30.5, so you have to dilate the sheath up to 18 French.
Distal position in the balloon,
Uh-huh.
and then we're gonna check the volume. We're gonna implant this valve with a 2 cc more in
Mhm.
the deflator. And we're gonna use the delivery system with the logo upside down, just to respect the anatomy.
So do you use a Gillis catheter to cross the valve?
Yes, sometimes it's necessary,
Mhm.
but we can see that Carlos.
Just Carlos will feel that.
Yeah.
Okay. Now Carlos is
I'm holding the
Oh, the
wire.
wire?
Marcelo is holding the wire, and Carlos is pulling the valve.
Yes.
Okay, can you bring the
Só
screen?
fix. Go ahead.
Okay, the valve is coming now.
I'm gonna do this under cine so that you can see better.
Let's see if you can go across. Yeah, okay, almost there. Okay, it was
very
easily.
easily.
Great.
Sometimes if you have problems coming from below,
Mhm.
coming from the IJ is a good idea as
Yes,
well. Can you
That's what
give me a
Dimitri
thought?
said.
The wire position is very, very, very important.
I think
So-
when you advance any device to the heart, you need to be very coaxial. That's, I think it's important. That was very
I
coaxial.
think it's
So could you see the valve?
So we are gonna do a very, very slow inflation because Carlos can make some adjustments during the deployment.
Okay,
And because we are in the right chamber, we don't need to pace to
So-
implant the valve.
so the pacing used is different from other mitral or aorta.
It's not mandatory to
Is-
pace
okay.
during a tricuspid valving.
Okay,
So
but you need to be so slow, and Carlos is paying
Slowly.
attention on this.
Okay.
So you're almost in the mid portion,
pouquinho.
okay?
Puxa,
Now inflating.
puxa
I'm
Puxa
trying
mais
to,
pouquinho.
so,
mais pouco.
yeah,
Tô indo.
Pode ir que ela vai ficar boa.
so slow,
Puxa mais pouquinho.
okay, it's still in the mid portion, the inflation is good, it's
Isso,
open.
pra cá, Puxa mais pouquinho.
It's a little bit more in the left, I would say 60% in the
All the way down.
ventricle,
All the
okay,
way up, all the way up.
well. Yes, I got you now.
Vamos ver? Isso.
You have about 70% in the right ventricle and 30% in the atrial.
Yeah,
That's a,
and I like, we can see the waist
Uh-huh.
and some flaring towards the ventricular aspect. And again, a little bit of flaring
So-
up to the atrium. I
and
think the valve, the position looks perfect. We're
Okay.
gonna see on echo.
okay, good. Let me ask you one question. I think it's important for the audience.
Precisa.
Puxar o balão.
Yeah, we're going to bring back the balloon now. Great. And Carlos, when you start inflate, we were about 50-50 in the left, in the right ventricle and the right atrial.
The thing is,
Then
because
the valve move a little bit ahead to the
no,
right ventricle. So you finish with 30% in the atrial and 7%.
yeah, we were
That's
planning
your
that.
objective?
Yeah, we are planning that because it's not totally horizontal, right? So you have
Yes,
to
I saw that.
come with more towards the 8.
Uh,
And then when you
uh,
adjust, when it becomes
There is
horizontal,
some inclination.
Yeah,
I could
yeah.
see that.
The major challenge
Yeah.
during mitral procedures
Yeah.
is the transeptal puncture.
Uh-huh.
You need to be at the right point.
I remember that
for
the first case we did.
septum. But when you were there,
Uh-huh.
I think it's
Okay,
a straightforward procedure.
so let's hear Simone, what is she's finding with the, now, Simone, the words is yours, please.
Okay, so we see here, it's hard to see the leaflets because we have a lot of shadow coming from the heart. But we can see part of the, let me get the here, the stent here. So this is part of the valve, the device, and here the other one. And we look for the flow across it. We see there is no more acceleration to the inflow, and there's a very mild regurg here, going very down here, maybe a little bit of leak, but very, very, very small. You see the ring of the valve, and we see the stent here, but it's hard to look at the leaflets.
but there is no significant regurgitation.
No.
When I first saw, I was under the impression there was a bit of paravalvular leak, but I'm not sure.
Yes, I was looking at it.
Near the septum.
Yeah, exactly.
Yeah, when
There's a little bit, but
Yeah.
very, very small.
on long axis, not on fast.
So what is the risk of a post-dilatation? It's important to mention it because now you're making a balance to post-dilate or not to dilate. So what is the risk?
I don't think that in the
if
Also
there
in the mitral,
there's a
we are
high risk.
scared about a left ventricle obstruction. Here, we don't have this risk.
Yeah.
Oh, and if it's a tiny risk, so I would leave it alone because
Okay.
we are on the right side.
Okay.
Right, so low pressure system.
Uh-huh.
If it's a very tiny leak, even paravalvular,
Even the
I want
the pressure is low.
Yeah,
So you already have a
A
large
huge-
right
yeah.
atrial. So
I-
that's an important considerations.
yeah. I
to
didn't
make this
mention,
decision.
Fausto, I didn't mention at beginning, my fault.
Yeah.
We had about 4 millimeter gradient. We have 10, 11 in the RA, the
Uh-huh.
mean pressure, and the end diastolic pressure of the right ventricle was about 7.
Oh, I see.
So 4 gradient, 4 millimeter. So the RA is already huge. It's a compliant chamber, so it's not causing, pressure
I see.
burden to the
What
to
we
the agent.
usually do during TAVR procedures is to exchange the stiff wire for a pigtail and just to evaluate the
Uh-huh.
echo.
Yeah.
And then if needed, we can place a wire again.
okay.
Gonna do that, huh?
The position is very good, as you see here. So it's mainly in the ventricle. And this is the tiny regurg probably related to the guide wire. And there is no evident leak paravalvulary, as you see, no regurgitation. So looks perfect, very
So what is your advice to Carlos, Simone? Should we post-dilate or not?
No.
How do you classify this kind of regurgitation? If you divide in 1, 2, 3, or 4?
No, I think the position is perfect and I wouldn't do anything else. I would stop here.
Okay, the regurgitates less than 1. I totally agree with you. Okay, great result.
Yeah, I don't think there is significant PR.
Okay,
I think we are done.
thank you very much, Guy. Congrats to you. It was a beautiful case, a very nice demonstration. You just changed a tricuspid valve in less than 40 minutes. That's unbelievable.
Great.
Go, see you later.
Bye-bye.